Chapter 24, Care of Patients with Peripheral Nerve and Degenerative Neurologic Disorders. Lesson 24.1, Care of Patients with Peripheral Nerve and Degenerative Diseases. Compare and contrast the pathophysiology of Parkinson's disease and myasthenia gravis. Examine treatments for Parkinson's disease. Discuss the nursing care needed for the patient with Parkinson's disease. Explain why multiple sclerosis might be difficult to diagnose. Identify the differences between Huntington disease and amyotrophic lateral sclerosis, or ALS. Recognize the signs and symptoms of myasthenia gravis. Compare and contrast the complications of Parkinson's disease with those of myasthenia gravis. Clinical practice objectives. Teach a newly diagnosed patient about the medications for Parkinson's disease. Teach a patient about the diagnostic tests that might be ordered if multiple sclerosis is suspected. Write a nursing care plan for the myasthenia gravis patient who is hospitalized with respiratory infection. Summarize a home care plan for a patient with multiple sclerosis. And choose a nursing care plan for a patient with Guillain-Barré syndrome. Parkinson's disease. Pathophysiology. Parkinson's affects the extrapyramidal system, in particular, the motor structures in the basal ganglia. This is the part of the brain that controls balance and coordination. So that makes sense when we think about Parkinson's. The cause of Parkinson's is a degeneration of the dopamine producing neurons in the substantia nigra of the midbrain and the presence of Lewy bodies. Signs and symptoms are going to be tremor. They may do a pill rolling tremor with their finger, their index finger, and their thumb. They also may have bradykinesia. You may see these people shuffle their feet. Rigidity. Drug therapy can help with this. We give them things like Cinemet or carbidopa levodopa. Physical therapy, emotional support, complementary and alternative therapies like distracting activities, aromatherapies, and then surgical treatment. They can actually go in and attempt to remove the part of the brain that is not working. Of course, we don't always do this, and this is extremely invasive. Synaptic activity. So here's a picture that shows what's going on, right? So you have the dopaminergic neuron, right? The dopamine and the dopamine receptors, the acetylcholine and the cholinergic neuron. And then you have the GABA and the substantia nigra. So what is going on? It is not picking up the dopamine. And so we have this akinesia and hyperkinesia outside of normal function, just depending on what's going on. Drug therapy, what can we give them? Anticholinergics, it's a big one. Why? They're going to have excessive salivation, etc. So this is going to dry them up. Dopamine agonists, so they can get more dopamine readily available. MAOIs, they block the metabolism of dopamine, which means that there's more dopamine in circulation. However, we need to be careful with MAOIs because if we take MAOIs and we eat products that are high in tyramine, like smoked meats, cheeses, fermented products, and beers, etc., it can cause issues with the MAOI. It can interfere, as well as meperidine with MAOIs can cause hyperpyrexia or excessive elevation of temperature, which can actually lead to death. It is so extreme. Drugs commonly used for patients with Parkinson's disease, just some more of them: anti-Parkinsonian adrenergic medications, antivirals, anticholinergics, there's those MAOIs, and then COMTs inhibitors. Patient teaching that they need to take their medication. They need to take it regularly. They shouldn't miss a dose. That they need to be careful what they eat because things that are high in tyramine, if they're on MAOIs, may interfere with their medication. That they need to get up and move, but they need to be careful doing so because their body may not be responding normally, and that they may have excessive salivation, and taking the anticholinergics may help. Multiple sclerosis, a chronic inflammatory disease that causes demyelination of the central nervous system. So the actual sheath around the axon is being destroyed. Inflammation may be a response to an environmental factor like bacteria, virus, or chemical, or just combined with a genetic predisposition for the disease. Signs and symptoms: motor dysfunction, Sensory dysfunction. These people can lose the ability to walk, lose the ability to lift their arms. They may have numbness, tingling, problems with coordination, mental changes like depression, fatigue, just overall feeling like their body just can't do it. How do we treat multiple sclerosis? Well, we can either give a treatment that's going to attack or modify the disease process, prevent attacks or modify the disease process, or we can give a medication that will treat the symptoms of the disease. So things like biologic response modifier drugs and stem cell transplants and such are going to prevent attacks and modify the disease process. Whereas medications like methylprednisolone and plasmapheresis, potentially even ACTH hormone, are going to help treat the symptoms. Nursing management. It is so important that we teach these patients about proper nutrition, making sure they're getting enough fluid in, enough fiber in, so that they don't have issues with constipation. Also, it helps to decrease the likelihood of UTIs if we do that. There are four general types of multiple sclerosis: relapsing remitting, which is the most common type. This is where the patient has exacerbations or flares of multiple sclerosis and they exhibit and experience symptoms during that period of time, but then they recover mostly back to baseline or go into remission, remitting. So relapse, remitting. Primary progressive, where the patients are not doing well and they show maybe an initial uh, positive recoup, but they end up just getting worse. So even though they'll never recover back to baseline and they'll always continue to get worse, we may see some um, uh, positive or remission type behaviors. Secondary progressive is just a continuation of this. It is a progressive illness, so it is going to continue to get worse. However, we may see some recoveries to baseline with secondary progressive as well. Relapsing progressive, however, is never going to get better. In fact, it's only going to get worse. And we may have episodes where it gets worse inside of the worse. So these are definitely in order of the most mild to severe, and relapsing remitting is the most common type. What are the effects of multiple sclerosis? Well, you see here the myelin sheath around the axon is destroyed, it's broken down. Chronic multiple sclerosis. You see a picture of the brain here. You see some damage to the actual brain itself, right? Some loss of that matter. Pathologic changes in the brain tissue of a patient can cause Alzheimer's disease. We don't know what the true etiology is, however. Considerable research is in progress to better define the disease. Alzheimer's has been studied for many years, and we have tried very hard to learn more about it. Alzheimer's can occur during middle age or during the later decades of life. So, early onset or typical onset Alzheimer's disease. Slow onset, progressing at various rates of speed throughout several stages, is usually how this goes. It's going to come on as forgetfulness and then eventually progress to the loss of all short-term memory. It eventually is fatal and eventually long-term memory as well. ALS, or amyotrophic lateral sclerosis. This is also called Lou Gehrig's disease. It's a progressive neuromuscular disease that's characterized by the degeneration of the gray matter in the anterior horns of the spinal cord and the lower cranial nerves. These patients are going to be weak, and especially in all the muscles that they can move on their own. They may have difficulty swallowing and speaking clearly. Because they're not moving their muscles, they will have atrophy of the muscles. Depression is definitely linked to this disease. That is a fatal disease. It is terminal, and death due to respiratory infection or dysfunction is the ultimate result of ALS. There is no cure to ALS. The patient ends up becoming totally dependent upon a caregiver. They can give a medication called riluzole, and it's a glutamate antagonist. It's only going to help relieve some of the symptoms for a short while. Eventually, it will be overcome by the disease. Eventually, these patients are going to be requiring ventilation, right? They will have impaired breathing. Initially, we can do BiPAP or CPAP, some non-invasive ventilation to help extend their life and delay the need for a ventilation, like an ET tube to be dropped or a tracheotomy, but eventually they will need a artificial airway and ventilation. Guillain-Barré syndrome, it's a relatively rare immune-mediated polyneuropathy disease that affects the peripheral nervous system. We don't know what causes GBS, but we do know that sometimes it follows a viral respiratory infection or gastroenteritis in an adult about 2 to 4 weeks afterwards. We also know that if you've had cytomegalovirus or Epstein-Barr virus, you're at an increased risk for developing the Guillain-Barré syndrome. Additionally, there is a slight tie to the flu shot and vaccinations. However, that has not been well established. Signs and symptoms. There will be pathologic changes, including demyelination, inflammation, edema, and nerve root compression. This is going to come on super suddenly. It'll start with mild sensations of numbness and tingling, maybe in the feet and hands, and then it'll eventually work its way into muscle pain, tenderness, and aching and paralysis. It typically works its way up from the toes to the head. However, it's important to know that it can start in the facial nerves and then work its way down from there. Progressive muscle weakness happens over 24 to 72 hours. What do? We support these patients. The big thing is eventually the paralysis is going to affect their lungs. So we have to make sure that we're maintaining adequate ventilation, controlling the pain that they're going to be experiencing adequately, preventing damage from aspiration, maintaining communication with these patients, maintaining adequate nutritional status, and returning the patient to a normal function. And that can happen. There are three big phases of Guillain-Barré syndrome. Acute phase, which is where all of the symptoms come on suddenly and we experience all of these changes. The static phase, where the motor loss and paresthesis no longer are progressing and we're somewhat stable, getting no better or no worse. The peak of Guillain-Barré syndrome can be 14 days. So 14 days of getting worse before we hit the static phase. And then the rehabilitation phase. Poliomyelitis and rehabilitation can take up to years, months to years. Poliomyelitis and post-polio syndrome, well, the motor cells of the anterior horn of the spinal cord, the brainstem, and the motor strip located in the frontal lobe are affected by polio. A virus can be prevented by immunization. We have two different types of immunization for polio. We have the Salk or killed virus, and we have the Sabin or the attenuated live virus polio vaccines. We need to modify the lifestyle of these patients to help them preserve energy and function. Huntington disease is characterized by abnormal movements with a decline in intellectual capacity and emotional disturbance. This is what makes Huntington so different. It is caused by an abnormal gene on the short arm of chromosome 4. It is autosomal dominant. That means 50% of um, uh, offspring can be affected by Huntington's disease. There is no known treatment to alter its course. There are drugs in trial, but no known treatment at this time. It is usually evident by the fourth or fifth decade of life, so 40s to 50s, but it may start to show up earlier. Women and men are equally affected by Huntington's. Myasthenia gravis. It's an autoimmune disease in which the T cell dependent immune attack is directed against the postsynaptic acetylcholine receptors at the neuromuscular junction. You have grave muscle weakness. Gravis means grave. These people are extremely weak. It is a chronic disorder. The muscular weakness can be so mild that it causes just a minor inconvenience, or so severe that it's life threatening in its effect on the breathing muscles and swallowing muscles. One of the clinical manifestations of myasthenia gravis is a unilateral ptosis. So that's what you would look for in a patient that potentially has myasthenia gravis, is a ptosis. Now, ptosis is the drooping of an eyelid. So not so much swelling, right? Swelling would not help. And they do ice tests where they apply ice to the eye and see if it reduces the presentation of the eye. If it does, then we know that that's not the case, right? Then we have the tensilon test. The tensilon test uses the drug tensilon to help your doctor diagnose myasthenia gravis, right? So tensilon is going to prevent the breakdown of acetylcholine, which is that neurotransmitter that our nerve cells release to stimulate muscles. People with chronic myasthenia gravis do not have normal reactions to acetylcholine. So because antibodies are attacking their acetylcholine receptors, right? So this means that the muscles cannot be stimulated and the muscles are extremely weak and fatigued. A person would test positive for myasthenia gravis if their muscles get stronger after they're injected with that tensilon. Okay. Blood tests for antibodies to acetylcholine receptors. This is going to show us if we do have some breakdown at those acetylcholine receptors, and our body has produced that autoimmune response to those acetylcholine receptors. Electrodiagnostic testing to test the actual strength of the muscles and response of the muscles to electrical stimulation. Chest radiography and chest CT. Treatment, what are we going to give them? Anticholinesterase agents are going to inactivate acetylcholinesterase, which is a substance that prevents the accumulation of acetylcholine at the neuromuscular junction. We want more of that, right? Anticholinesterase agents will temporarily increase muscle strength because they allow the acetylcholine to work. Problem is they don't cure it, they just treat the symptom. Additionally, we can remove the thymus gland. We know that the thymus gland has a part in the immune system. And if we remove the thymus gland, then we can potentially prevent the production of the immune response to these acetylcholine receptor sites. Nursing management, we can go into a myasthenic crisis, right? Not good. It's basically the worst presentation of myasthenia gravis. So what can we do to support these people? We can what causes the myasthenia gravis? Typically, infection causes myasthenia gravis crisis. So infection not only in and of itself can cause an issue, but it can also exacerbate the respiratory depression that happens, right? So you will see breathing that's maybe fast or shallow, usually higher than 25, 26 breaths per minute. They may feel really short of breath or have a hard time speaking, chewing, or swallowing. They may have to pause and take a breath while they talk. They may have a weak cough. They may have trouble holding up their head. What causes it? Like I said, infection is going to cause it. If they're sick, it's going to stress their immune system and it's going to exacerbate the issue. Also, if they're taking meds like antibiotics or steroids or blood pressure medicine, we need to be careful for those because they can exacerbate the issue. Surgery itself can cause a myasthenic crisis. So be careful for that. Also, pregnancy or any other kind of physical or emotional stresses can induce that myasthenic crisis where the exacerbation is so bad that it may affect the lungs. Rehabilitation goals, we need to educate patient and family and support patient and family as they navigate this disease process. And that is it. Okay, guys, if you have any questions about chapter 24, don't hesitate to reach out.